Okay, our last speaker of the day is, I'm hoping I pronounce this correctly, Dr. Luciano Kapelusznik. He is an assistant professor of medicine at University of Maryland since 2011. He's also works at the Institute of Human Virology there, and he has been teaching, doing direct patient care, and clinical research. His main expertise is viral hepatitis, including C, and he leads 2 hepatitis C clinics at the University of Maryland, and he's the principal investigator in 2 large pharma-sponsored interferon-free clinic trials and a co-investigator in a large pharma-sponsored clinic trial in hepatitis C and HIV co-infection. And he will be talking to you today about hepatitis C and STIs. And he will be leaving a little early, so we're going to see how we can get through all this.
Hello, thank you for having me here today. So I'm going to start talking about hepatitis C, and then we're going to move on to STIs. So just a little bit overview to put hepatitis C into perspective. There's about 170 million cases of hepatitis C worldwide. That compares to about 35 to 40 million of HIV and 350 million of hepatitis B. In the US, there's about the same amount of people infected with hep C than infected with HIV, about 4 million. And also it's important to note that about a third of the patients that have HIV are co-infected with hepatitis C. Hepatitis C, as you know, is silent for many, many years, so a lot of the patients are infected with hepatitis C are actually unaware that are infected. A brief overview about hepatitis C. Hepatitis C comes in several genotypes, but the most common are 1 to 6. And in the US, genotype 1 is by far the most common genotype. 80% of the patients in the US have genotype 1. And unfortunately, genotype 1 is the most difficult to treat. Genotype 2 and 3 are the next 2 most important genotypes in the US, and about 16% of the patients have those genotypes. Other genotypes are less common in the US. Genotype 4, for example, can be seen sometimes, particularly in patients that are immigrants from the Middle East. And I want to talk about some of the treatments that we have now and the treatments that are coming in the next few years for hepatitis C. So the goal of treatment of hepatitis C as opposed to HIV is a cure. Of course, everybody wants to cure HIV, and there was a patient in Germany that you might have heard about that was, technically cured from HIV. But most patients, as of today, cannot be cured, and the reason for that is that the RNA of the HIV virus gets transcribed into DNA, and that DNA integrates into the nucleus of the cells, and it can be eliminated. Hepatitis C, however, doesn't do that. The RNA doesn't get transcribed into DNA, and therefore it doesn't go into the nucleus of the cells, which means that it doesn't persist. So we can actually eradicate hepatitis C from the body, so you can actually cure it. Nobody dares to call it cure because in some cases it can come back and can relapse. We know now that most of the patients that are negative for hepatitis 6 months after treatment, they don't relapse, and it is thought that the ones that relapse, which is about 1%, is actually a reinfection and not the actual relapse. But still, historically, we don't call it a cure, we call it SVR. And SVR means sustained virologic response, but technically speaking, it's about the same. So why do we want to achieve an SVR? Because if we do, we can slow or stop the damage to the liver. And as you know, the main problem with hepatitis C is scarring of the liver, which can result in cirrhosis, liver failure, and death. It can also predispose people to get HCC, hepatocellular carcinoma. So what treatments are available as today? So hepatitis C used to be called hepatitis non-A, non-B until 1992, when a test for hepatitis C was developed. In 1992, people noted that if we treated patients with interferon, some of them will be able to get cured from hepatitis C. So for the last 20 years, from the 1990s until 2011, all we had available to treat hepatitis C was 2 medications, interferon and ribavirin. Interferon was modified with the years and pegylated what we know was pegylated interferon or Pegasus, and that's just a modification to the molecule of interferon. Then ribavirin was added later, but for 20 years we have about the same treatment. The problem with that treatment is that it's highly toxic and also it's not that effective. Depending on which patient population we are talking about, the response rate of SVR rates are quite low. For all comers, it's about 40%, but certain groups have a much lower response rate than 40%. For example, people with very high viral loads, people with difficult to treat genotypes, people with a lot of liver scarring, people from African descent, people that are co-infected with HIV. These groups are all groups that respond much lower. For example, if you are co-infected with HIV, your response rate will be in the order of 20 to 25%, so quite low. So pharmaceutical companies took note of this and they started to develop compounds that target the hepatitis C virus directly. Something about interferon and ribavirin is that these drugs do not target hepatitis C directly. We know that HIV medication, for example, target certain proteins of HIV, right? You know protease inhibitors, they target the protease enzyme, NRTIs that target the reverse transcriptase. But interferon, what it does, interferon is a natural substance that we release in response to viral infections. So when we're giving interferon as an injection, all we're doing is basically revving up the immune system. Ribavirin, we don't know exactly the mechanism of action. There's several proposed mechanisms of actions, and none of them is directly antiviral. But we know it works. But the pharmaceutical companies started to develop compounds that would target the hepatitis C virus directly. And the first two that got approved in 2011 are called boceprevir, which the commercial name is Bacterialis, and telaprevir, the commercial name is Incivek. These were approved, as I said, in 2011, and unfortunately, because hepatitis C develops resistance very quickly to these compounds we're giving as a monotherapy, they need to be given in combination with interferon and ribavirin as of today. And of course, the downside of it is that we still have the same side effects that interferon and ribavirin have on top of the new side effects of the new drugs. The upside is that I'm going to show you in a few slides the SVR rates, the response rates increased dramatically. So I just wanted to show you this representation of the genome of hepatitis C. And you guys don't need to memorize it, but just to show you that there's several targets that can be used to produce new medications against hepatitis C. For example, the same as for HIV, hepatitis C uses a protease to process their enzymes. And we can target this protease. For example, telaprevir and boceprevir fall into this category to inhibit hepatitis C. There's other proteins, for example, a protein called NS5A, that is a non-structural protein, and we don't know exactly what it does, but we know if we inhibit it, we can actually also decrease dramatically the hepatitis C viral load. And finally, there's a protein called NS5E, which is a polymerase, which will be the analog of a reverse transcriptase in HIV, only that instead of transcribing RNA into DNA, just copies RNA into RNA. And we can also inhibit this protein. And these medications will be analogs to NRTIs and NARTIs on the HIV. Okay, so a little bit more about telaprevir. One of the things about these new FDA-approved hepatitis C compounds are they're only effective against genotype 1. And as I told you before, genotype 1 is 80% of the patients in the US. So this is definitely an upside, but we still have 20% of patients that are not going to be able to take medications because they have genotypes other than 1. Also, these medications are approved for patients with cirrhosis, but they shouldn't be used for patients with decompensated liver disease, which means those patients that come to your clinic, with a big belly full of fluid, or looking completely yellow, with GI bleeds, which are really the patients that need to get treated the most, because they're the patients that are at highest risk of dying from hepatitis C. These drugs are being tested right now for patients co-infected for HIV, and they are not FDA approved for the use in patients with HIV. We have pretty robust data that they work for patients with HIV as well as they work for patients without HIV. As a matter of fact, the Department of Health guidelines were released last year, and they recommend the use of these drugs for patients with HIV despite not being FDA approved just yet. The phase 3 clinical trials are on the way as we speak. The good thing about using these drugs for patients with HIV is that the response rates are exactly the same as for patients without HIV, whereas, as I told you before, if we just use interferon and ribavirin, patients with HIV have a disadvantage because the response rates are much, much lower. One of the issues, the same as with TB drugs, is that these drugs inhibit the cytochrome P450, which is one of the enzymes that is in charge of metabolizing a lot of enzymes. So they can have pretty strong drug-drug interactions with a lot of HIV drugs. But every day there's more data coming out of how to adjust these medications when you're using it with certain drugs. A lot of the new drugs for HIV, for example, raltegravir, doesn't seem to have any drug-drug interactions because that drug doesn't use the cytochrome P450. But the ones that we have to be more aware of are the HIV protease inhibitors such as Persista or Reatas that can have a pretty strong interactions. The other thing about these new drugs is that they need to be taken 3 times a day, so that can be a downside for a lot of patients. Telaprevir needs to be taken with 20 grams of fat, and that's a lot of fat to be taken 3 times a day. Interferon, one of the side effects is decreasing appetite. So these patients have no appetite, they're feeling a little sick, and they need to eat really rich fatty meals. So it's a lot of times that's a problem. Telaprevir is used only for 12 weeks. So I'm gonna show you in a few minutes. The treatment for hepatitis C used to be 6 to 12 months for people with genotype 1. Most of them will get 1 year. And when we use telaprevir, we are able to shorten the treatment to 6 months in a lot of these patients, depending on how quickly they respond to treatment. But you would treat them with 3 months of the telaprevir, and then you will complete the rest of the therapy with PEG and RIBA to 6 or 12 months, depending on how quickly they respond to therapy. Boceprevir is the other one. This from a different company, Bacterial. The mechanism of action is the same, and as a matter of fact, if somebody fails one of these drugs, he shouldn't get the other because there's cross resistance. The indications are also the same for patients with genotype 1 infection, same as with HIV. It's being tested. There's a lot of drug-drug interactions. In this case, it's also 3 times a day. It needs to be taken with food. This drug, the upside doesn't require fatty food. The downside is that you need to take it for longer than the telaprevir. The telaprevir, you need to take it for 12 weeks. And the boceprevir, you will take it at least for 24 weeks. Some people need to take it for the full year. So just to refresh your minds about the side effects of interferon and ribavirin, and if you have seen patients that are on treatment, you will not forget some of the side effects. The most common are flu-like symptoms, and I told you that interferon is a natural substance that is released when people get infected with viruses. So think about having injection-produced influenza. People get muscle aches, headaches, fevers. They feel like if they have the flu. It can also cause psychiatric symptoms, and a lot of the patients with Hep C are former substance abusers, so a lot of them have a lot of psychiatric comorbidities. It can exacerbate depression, difficulty sleeping, irritability. So that's also one thing that you have to take into account when you're going to use these drugs. There's also less common side effects to these drugs. But they can be also, very bothersome to the patients, hair loss, weight loss. It can cause autoimmunity because, as I told you before, interferon revs up the immune system, so they can have autoimmune thyroid problems, predisposition to infections. and obviously this cannot be used on women of childbearing age until they're unless they're taking contraceptives, because ribavirin is highly teratogenic. So on top of that, now we have the side effects of telaprevir and boceprevir. So telaprevir, the hallmark side effect is rash, and about 50% of the patients will get a rash, so that's a pretty large number. Most of the rashes are mild and can be treated just with topical steroids. Sometimes the rashes can be more important. And when telaprevir was approved, there were no reported deaths, but post-market, there's been a few deaths reported from Stevens-Johnson syndrome, which would be the most extreme form of rash. And there's a black label now on telaprevir saying that it can in certain patients it can produce death from skin reactions. So if this is not the medication that you want to give to somebody who has underlying skin problems. Can cause other symptoms that are also not very pleasant. A lot of patients complain of anal rectal burning, and we don't know why, but it's a very uncomfortable side effect. And it can exacerbate some of the side effects of interference, such as low blood counts, white cells, red cells, and cause some GI side effects. Boceprevir doesn't cause a rash problems, but it does cause something called dysgeusia, which is altered taste. It can also exacerbate the cytopenias, the low blood counts, and it can also cause GI symptoms. I want to show you the data, why we use them if they are so toxic. So this is pretty much the SVR, the response rate for patients treated with peg-and-riba, about 40%, 44% on this study. And when we use telaprevir added to peg-and-riba, we have a response rate of 75%. So that's pretty impressive. 3 out of 4 patients that you're going to treat are going to get cured from hepatitis C. Okay, this is a cure. They don't have cirrhosis, they don't have to come and see you anymore for hepatitis C. With telaprevir, there's also discrepancies in terms of response rate in certain groups. For example, there's racial differences. White people get about 75% response rate. Hispanic people get about the same, but people from black descent have a low response rate. We didn't know why, what was the reason for this until a group, two groups, one group out of Hopkins and one group in China did something called a genome-wide analysis, and they found a gene that is associated with low response to interferon. And the gene can come in 3 different flavors, and there's a flavor called CC that is very common in Asian people and in whites and Hispanics, and that produces very good responses to interferon. But people from African descent, they don't have this CC gene, they tend to have a TT or CT, which produces a lot of resistance to interferon. So that would partially explain why there's racial differences in response to hepatitis treatment. There's also differences in response to hepatitis treatment based on how much liver fibrosis you have. And people that have cirrhosis, which is the extreme amount of scarring or fibrosis, they're going to respond less. And of course, people that have cirrhosis are the ones that you want to treat the most, because are the ones that are at higher risk of developing liver failure, liver cancer, and death. There's also differences in response of whether your patient was treated before or not. If your patient was treated before and didn't respond to interferon and ribavirin, if now you want to treat him with telaprevir, look at this. Only 29% will respond. Although if you just treat him with peg-and-riba, again, only 5% will respond. But if you have somebody that responds partially, which means the viral load dropped a little bit, but not enough to clear, the response rate is higher. It's 59% versus 15% if you treat them with just peg-and-riba. People that relapse are those that were negative at the end of treatment before with peg-and-riba, but then the virus came back. And if you retreat those patients, 83% will get cured this time versus 24% only if you treat it with just peg-and-riba. So as you can see, the medications that are really effective are also really toxic. So every patient that comes to clinic, we need to very, very thoroughly weigh the pros and cons, assess what kind of conditions they have, psychiatric illness, underlying autoimmune disease, how likely they, just general health, how likely they are to be able to withstand treatment, because we don't want to start these treatments on patients that are gonna, get seriously ill. Just to give you an idea of how ill they get, I would say that they get as ill as if they were getting cancer chemotherapy. Okay, they will come at 4 weeks with a 5-point hemoglobin drop, almost always, just feeling sick, abdominal pain. They have to come to clinic every week or every other week. You have to support them. So the treatment is really, really rough, but the reward is really high. You get cured from hepatitis C and you don't have to think about it anymore if you get cured. So definitely a high price to pay, but a very high reward as well. And just to show you what I told you before about HIV co-infection, if you're co-infected and you use these drugs, also 75% response. So that's good news for people with HIV. Now they have something that is pretty effective if you are co-infected with HIV. And some of the insurances are paying for the drug. Just to give you an idea, this drug costs about $50,000 for the treatment course. It's very expensive. But some of the insurances are starting to pay for HIV drugs because they realize that a liver transplant is $1 million, so it is really a bargain if they can get somebody cured from hepatitis C. So the most attractive part about hepatitis C is not the present, but it's the future, and because there's so many patients infected with hepatitis C around the world, the companies see dollar signs. And they started to develop different compounds to treat hepatitis, and they target all the different proteins that I showed you before, the polymerase, the NS5A, and the protease. So right now there's about 25 new compounds on advanced development. Advanced development means stage 2 or 3. I want to show you some data because it's really, really impressive. Several of these combinations are interferon-free. Interferon-free means you don't have all those nasty side effects that we were talking about. Cure rates as high as 100%. So these treatment combinations are ideal. Very little side effects and close to 100% cure rates. And when is that going to happen? It's not going to happen. In 10 years, it's going to happen probably beginning of next year. There's a couple drugs that are already filing INDs to get approval from the FDA. So if things go well for those drug companies, some of these medications are going to be in the market very soon. So I'm going to show you some data. Gilead made a drug called sofosbuvir. This is a nucleotide inhibitor of the Hep C polymerase, and they combined it with cimeprevir, which is from a different company, Johnson & Johnson, which is a second-generation protease inhibitor. And they tried it with and without ribavirin. So this is the results. When they combined it with ribavirin, 96% of the patients got cured. Without ribavirin, 93% of the patients got cured. Okay, this is patients non-responders, which are, let me remind you, non-responders are this. With the current treatments, about only 30% respond, and with the prior pegol-riba, only 5%. So now the non-responders, almost 100% are responding to treatment. What are the side effects? None compared to placebo. No GI, no anemia, nothing. These treatments are only for 12 weeks. So also, one of the reasons why they have very little side effects and no side effects because the treatment is so short that it doesn't give time for a lot of the side effects to even appear. So this is another study. The same drug, sofosbuvir, is, by the way, the $11 billion drug. I don't know if you guys hear about it. Gilead paid $11 billion in the biggest pharmaceutical acquisition in history to buy this drug from a small biotech company because they saw such a huge potential on the drug, seeing that there's 170 million people around the world with hepatitis C that could be treated. But when they combine it with another drug called ledipasvir and ribavirin for 12 weeks, Again, in naives and non-responders, 100% got cured, 100% got cured. Okay, and what are the side effects? In this case, side effects, as you can see, there was not much difference between severe side effects on the different arms, and the side effects, as you can see, is a pretty low amount of side effects. You can see that 0 patients had to discontinue in these arms for side effects. 1 patient had to discontinue in this arm for side effects. There's pretty much very little anemia to no anemia. There was only anemia on the patients that got ribavirin. A little bit of headaches, some ligament sprain, but nothing major. Other companies, Abbott also has a combination treatment, combining 3 drugs. This is an inhibitor of it's a non-nuc. It's an equivalent of NNRTIs for HIV. This is a protease inhibitor, and this is an NS5A inhibitor with ribavirin. In their case, 92 and 93% of the patients got cured. These are naives, and these are null, the ones that have a very poor response before. Yes? So this medication, the rumor is that they're going to put in for an IND at the end of this year. So if they are able to get through the FDA, I think next year it's going to be available on the shelves. What Gilead wants to do is they want to do the same thing that they did for HIV with a tripla, where they want to do a 1 pill once a day that will have a combination of different drugs. So I don't know if I have it here. No. So they combined it with another drug that they're also developing, and they also have high response rate, and they're gonna try to release the drug as a combination pill. So you would take 1 tablet once a day, and for 12 weeks, and you will cure, regardless of what genotype you have, regardless of your race, regardless of the viral load, regardless of whether you responded to treatment before you're treatment naive. That's what they want to do, but they probably going to release the fosfivir alone, in 2014. So that's the hepatitis C part, and I'm gonna have to rush a little bit through STDs. So just to give you a perspective of what STDs are more common, and HPVs, and trichomoniasis are the most common, followed by chlamydia, herpes, gonorrhea, Hep B, and syphilis. And in terms of chlamydia, it's the most common reportable infection in the U.S. And most cases are asymptomatic, and is the leading cause of preventable infertility in women. And as you can see here in this slide, taken out of the CDC website, the rates of chlamydia have been increasing in the U.S. on the last 10 years. These are the data for Maryland, and you can see also in Maryland there's an increase on the rates of chlamydia diagnosed in the state in the last 7 years or so. Remember that if you have untreated chlamydia, patient with untreated chlamydia, about 20 to 50% of them can have either acute or silent PID, which is pelvic inflammatory disease, and that can lead to ectopic pregnancy in a number of them, chronic pelvic pain, or infertility. These are just some pictures of what chlamydia looks like, which is typically a non-purulent, clear discharge from the cervix or the penis. And it's been proven that chlamydia screening and treatment decreases community prevalence and prevents PID, and is cost effective. The chlamydia screening recommendations, the most updated ones, are that all sexually active women under 26, they need to be screened for chlamydia on the initial screen, and then annually, and then you should repeat it if the patient had new or multiple sex partners, a couple of months after the infection. Pregnant women under 26 also need to be tested for chlamydia, and men only if they have new or multiple sex partners or they have inconsistent condom use. In men, chlamydia typically doesn't cause chronic disease, but men can have acute urethritis, or of course can be chronic carriers of chlamydia and pass it on to women. The treatment for chlamydia right now, it hasn't changed much from the past. It's still azithromycin 1 gram, only 1 dose, and that takes care of it. And doxycycline for patients that can tolerate azithromycin. You could potentially use erythromycin or quinolones also to treat it. For gonorrhea has been on the news a lot lately because it's increasing resistance. It's pretty common in young adults and adolescents. Remember that 40% of the patients that are diagnosed with gonorrhea, they also had chlamydia. That's what the guidelines recommend, to either to test or to treat everybody for chlamydia that gets diagnosed with gonorrhea. And resistance is a problem. This is a graph of gonorrhea in the last decades, and as you can see, there was a peak in the 70s, and then it started to decrease again. And since 1996, the rates are pretty much stable. This again, gonorrhea by race, and you can see that there's a disparity among races in the sense that people from black descent have higher rates of gonorrhea than people that are white, Hispanic, or Asians. This is the gonorrhea rates by state, and we can see that there's more gonorrhea on the eastern side of the United States, also in Alaska for some reason. And in terms of Asian sex, you can see that gonorrhea is a disease that happens to young people. I would say that most of the people are from between 15 and 30 years of age. It's pretty much equally distributed among men and women. And gonorrhea is much more purulent than chlamydia. You can see here that the discharge that produces in the cervix and the penis is typically a purulent discharge. And the most important thing that you need to know about gonorrhea is that there's increasing resistance to chlamydia, from gonorrhea to antibiotics. In Asia, for example, almost all the gonorrhea isolates are resistant to Cipro right now. In the US, the resistance to Cipro varies between 10 to 30%, and you can see here that Hawaii and California have pretty high rates of resistance in the 30% range, and the rest of the US, the resistance rate is about 10%. So Cipro, quinolones are no longer recommended as a first line of treatment for gonorrhea. Yes. What is resistance? Well, probably several reasons. One is probably overuse of quinolone antibiotics. If you have either patients that were treated for gonorrhea or patients that were treated with quinolones for other things, for UTIs, pneumonias, and they had gonorrhea at the time, gonorrhea starts to develop resistance.
I'd like to add to that, gonorrhea is a bug that figures out the medication. Because we used to use penicillin, it's resistant to that. Tetracycline is resistant to that. So that's why they're recommending now for us to use the medication, ceftriaxone, and your chlamydia treatment, so it won't become resistant to the ceftriaxone. Because we don't have any other drugs down the pipeline at this point. Am I correct on that?
That's right. And you can see that there's a disparity of Cipro resistance by the sex of the sex partner. So gay men have much higher rates of Cipro resistance than straight men. Men that have sex with men and men that have sex with women. And you can see here that the disparity is pretty obvious. There's also increasing resistance to cephalosporins, unfortunately. And you can see that almost 4% of isolates collected for men that have sex with men had reduced susceptibility to cefixime. Cefixime is a oral cephalosporin, and it's not recommended any longer by a lot of Department of Health. The Department of Health of Maryland, the Department of Health of New York, they released guideline statements in the last few months, and they recommend against the use of oral cephalosporins to treat for gonorrhea. Reduced susceptibility to ceftriaxone, fortunately, is not widespread yet. About 0.4% of all isolates and about 1% of the isolates on MSM. These isolates are resistant to ceftriaxone. There's virtually no way to treat it. So how do you screen for gonorrhea? You need to consider screening on target populations where the prevalence is 1 to 2% or more. Typically, men have sex with men, and high-risk women, young age, multiple sexual partners, or pregnant. Lastly, syphilis. And I'm sorry I'm going so quick, but time is short. So you can see here that there was a lot of syphilis in the 1940s, but with time it came down and it's been stable ever since. There's an outbreak of syphilis in certain groups in the U.S. that's been going on for the last decade or so, and you can see here that men that have sex with men, they have an increasing rates of syphilis in the past decade or so. Here you can see the rates of primary and secondary syphilis, and you can see again that men that have sex with men have much higher rates of syphilis than women and men that have sex with women. And you can see that there's also a little bit of a racial disparity. In this case, whites and blacks have about the same amount of syphilis, and Hispanics and others have lower rates of syphilis. In terms of the U.S., there's a lot of syphilis all around, but mostly on the west, south, and on the east. On the Great Plains states, there's not a lot of syphilis. In terms of age and sex, you can see that syphilis is much more prevalent in men than in women, right? And the age distribution is a little bit more uneven than for gonorrhea. Gonorrhea, I show you, that is mostly a disease of young people, but syphilis, you can see that it starts to appear on teenagers, but you can have pretty significant rates of syphilis throughout. So in terms of reported rates of syphilis by sex and sexual behavior, again you can see here that MSM have a lot of secondary syphilis, and also high rates of primary syphilis compared to men and straight men and women. I'll skip all this because we have time. And how does syphilis presents? Primary syphilis presents with a chancre, but it can also be in appearance, especially in women. They can have internal lesions, and because the lesions are painless, they may even not know that they have syphilis. Secondary syphilis presents a lot of times with a rash. The hallmark of the rash is that it doesn't spare palms and hands, and they can also present with genital warts, with meningitis, cranial nerve pulses. You can see here that oral lesions are not uncommon. These are the warts. Alopecia is also another presenting sign. And how to test for syphilis? So this is something that you should know. For primary syphilis, the serology may be negative. So if you have somebody that comes with a chancre and you think he may have syphilis, and you send him for syphilis testing and it comes back negative, that doesn't rule out syphilis because it takes several weeks for the syphilis test to come back positive. So the way to test for primary syphilis is not serology. I mean, you can do serology as long as you know what to expect. The way to test for primary syphilis is doing a dark field microscopy. That's not done in most centers except in STD clinics, and you can also refer to your local Department of Health, and they can do it there. In clinical practice, a lot of times somebody presents with a chancre, you think it's syphilis, looks like syphilis, you just treat them. So the CDC recommends to start testing for syphilis with a non-treponemal test. So we have two types of tests, treponemal and non-treponemal. The non-treponemal are typically the RPR and the BDRL, the treponemal, the TPPA or FTA. So you basically start with a non-treponemal test, your RPR, and if your RPR is positive, you want to get it titer, and you also want to confirm it with a treponemal test. RPRs can be false positive, as you saw on the prior case. There's many reasons why RPRs can be false positive, but the FTA is never false positive. Your FTA is positive, or your TPPA, which are the treponemal tests. It's syphilis. Many labs are using right now treponema pallidum EIRs or CIAs, which are treponemal tests to do screening for syphilis. And this is what they do basically is they reverse the order that they recommend by the CDC. And what they do is if you have a positive treponemal test, they will confirm it with an RPR. Okay, so they reverse the order. The CDC doesn't recommend this, but it seems to be more cost effective for a lot of medical centers, or a lot of medical centers are doing this. Now, if you have a positive treponemal test, like an EIA or a CIA, and your RPR is negative, you need to do another test, a TPPA or an FDA, to see if you have syphilis or not. And if your TPPA or your FDA are also negative, it means that your treponemal test that you did initially, the EIA or the CIA, was a false positive. And this can happen in up to a third of the specimens, okay? So you have to be very, very careful.
I would suggest if you have concerns or issues or questions about any of that, contact your local health department. Because I know that my medical director, Dr. Rapallo, who knows syphilis, consults with the state about different issues like this. So when you have someone in your provider that is offering care and you're just not quite sure where to go, or you have a difficult case, consult the local health department, the state health department, and someone can get you to the right person.
So this is the algorithm of how you should test. So this is what the CDC recommends. Basically, you do an RPR, and if it's positive, you get a titer, and then you check a TPPA or FDA, which are the treponemal test. And if you're positive, you have confirmed syphilis. If you're negative, you have a false positive RPR. Remember that having a positive RPR and a positive treponemal test doesn't mean that you have active syphilis. It may mean that you had syphilis in the past and got treated for it. So you always need, when you have a positive syphilis test, you always need to ask your patient whether they received treatment in the past or not. People that have active syphilis tend to have higher titers than people that were treated in the past. What is a higher titer? Higher titer is anything more than 1 to 2. 1 to 4, 1 to 8, 1 to 16. Anything like that is typically, you have to think about active syphilis. But you can have active syphilis with a low titer too. And what's more commonly done in a lot of hospitals, you get your syphilis EIA, and if it's positive, you'll get an RPR. If it's positive, you confirm your syphilis, and if it goes negative, then you get the other secondary test, the TPPA or the FDA, and if it's positive, then you confirm your syphilis. But if it's negative, it was most likely a false positive. But in patients that are at high risk for syphilis, so you have men that have sex with men that don't use condoms and they're co-infected with HIV, you do want to repeat that RPR after a few weeks because it may be on the window period where the RPR was negative. So how do you treat? Treatment for syphilis hasn't changed. You still use the penicillin as a first option. As a matter of fact, penicillin is the only treatment that is available for pregnant women and for neurosyphilis. Alternatively, for non-pregnant and non-neurosyphilis, you could use doxycycline if the patient is penicillin allergic. There's other treatments that have been studied, such as giving azithromycin at a high dose, which can be effective for early syphilis, but there's some degree of resistance, so it's not ideal. The same for ceftriaxone, but again, you don't want to use this. If you can, you use penicillin, and if you can't, you use doxycycline except on pregnant or neurosyphilis.
And I would say on the penicillin, make sure it's long-acting, because there's a short-acting, and that does not work well. We always recommend a long-acting penicillin.
Yeah, that's a good point. The penicillin needs to be the long-acting benzathinic penicillin G, which would be from 1 to 3 injections, depending on whether the syphilis was early or late. But we don't have time to go into that right now. So as a summary, there's a lot of new drugs that are available for Hep C that increase the likelihood of cure, but are less toxic and more efficacious. But the less toxic and more efficacious drugs are in the pipeline, and hopefully will get approved, as soon. Chlamydia is on the rise in the U.S. GC is increasingly becoming resistant, and syphilis has made a comeback on certain groups, especially among, there's a lot of African Americans, MSM, that have syphilis. I didn't have time to show you that slide. And there's 2 ways to go about testing for syphilis. You can choose to follow CDC guidelines, or if your local hospital, reverts the sequence, you need to know what to do if you have a negative RPR to rule out syphilis appropriately. Okay. Yes.
twofold question. Is there any danger of a Hep C epidemic?
Well, there's already a Hep C epidemic.
There is?
Oh, sure. There's 170 million cases around the world. There's also an epidemic of acute Hep C among men that have sex with men co-infected with HIV. We used to think that hepatitis C was mostly transmitted through intravenous drug use or contaminated needles, and sexually there's very little transmission. But most recently, in the last decade or so, there's been a lot of cases of men that have sex with men that are co-infected with HIV that get acute Hep C, transmitted sexually.
So the second part of my
Yeah.
question then is, are you aware of any political will to fund treatment for people with Hep C?
Well, that's a good question, and I think the government took notice that hepatitis C is a big problem. As a matter of fact, parahepatitis surpassed HIV last year as a cause of mortality in the U.S. I think the government took note of that. They changed the guidelines for screening. So now there's guidelines for screening on everybody that is a baby boomer. I think it's 1945 to 1965, because baby boomers used to do a lot of drugs in the 60s. There's a lot of baby boomers with Hep C. So they changed the guidelines, and now every baby boomer needs to be tested for hepatitis C, regardless of symptoms, regardless of LFTs. But there's also many other groups that also are high risk of Hep C and need to be tested. That will be the first step. Once we can uncover, how many occult cases of Hep C we have in the country, then the next step will be, providing funding to treat Hep C. I think they're waiting on the new drugs to come out, because you can't massively distribute drugs that are so toxic like the drugs that we have right now. Yes.
You mentioned something about the genotype 1. You said it was 80% of
80% of the U.S. People infected have genotype 1.
how many genotypes are there?
There's the most common are 1 to 6. Yeah, in the U.S. I would say that 1 to 3 are the most common, but the most common of all is genotype 1.
And for the treatment, do those side effects for Hep C, do those side effects span the duration of the treatment, or are they just like maybe in the beginning?
Well, some of the medications, for example, the Lapravir is only for 3 months, so those side effects are going to be there for the portion of that medication, and the side effects tend to get better as you go with treatment. They're much worse at the beginning, so people, I don't know if the side effects go away or people learn to live with them, but people tend to feel better as treatment goes by. A lot of the side effects persist though. The risk of cytopenias, of anemia, leukopenia, that persists. The fatigue a lot of time persists, but some of the side effects do get better. Yes.
So the new drugs that are coming out for hepatitis C, are there some that will take into consideration pregnant women?
Well, right now, none of the drugs have been tested in pregnant women, because they're experimental, and the first thing that they do is they highly select the patients for the clinical trials, and they exclude pregnant women. So we don't know, if these drugs are safe for pregnancy or not.
Okay.
Probably, Hep C during pregnancy is not such a big deal as is HIV, because the transmission from mother to child is much lower than for HIV. There's transmission rate is about 5%, and you can always wait. If you have drugs that are effective, we can always wait and treat the mother after, she delivered, and we can treat the baby, after he's born, if he develops Hep C. And Hep C is also a very slow virus. It takes 20 to 30 years to people get cirrhosis. So even if a baby has Hep C, you will wait until he grows and treat him later. So you have much more wiggle room than with HIV. Yeah.
I just want to mention that there are patient assistance programs right now from sub-year or second-year for clients with insert into the guidelines. So some of the clinics now are really making a push to try to get those treated who are at most advanced risk to have those assistance.
Absolutely. And I have to say that when these drugs came out to market, we were really enthusiastic about treating a lot of these patients, and our enthusiasm is winding down, because we started to see, how sick the patients get. The patients get much sicker than the patients on the clinical trials. probably because the patients in real life are sicker than the ones that are highly selected in clinical trials. And seeing what's coming, we are very, very cautious to start these medications on patients that have some time to wait for the new drug. But for the patients that need to be treated right now, which are typically the ones that have more advanced liver disease, you're right. You can get patient assistance and to try to get them into treatment. If the FDA is negative, the patient doesn't have syphilis. I have to say that the 1 to 128 is a very high titer for a false positive, but the FDA is a very highly sensitive test. So if it's if it's negative, it's negative. You may want to consider repeating the tests in a few months, but most likely the patient doesn't have syphilis. FDA typically appears after a few weeks after the patient gets infected, so it's possible that you may have been on the window period. So you wanna repeat the test to make sure that you didn't miss that, but it's unlikely that the patient is infected.
And if you have cases like that, like I said, you can email us. I'm with the Prevention Training Center. Like I said, we can have Dr. Rapallo or someone that we work with in infectious diseases help you with some of those difficult issues or questions. But we would need to get probably more information on reference to that patient.
All right.
Based on the case.
Yeah. So the case, I think the things that caught my attention are one is that what do you guys think? How did this woman get syphilis? Was it from her partner, or was it from the one night stand that she had?
Father of the baby who was having sex with you.
Well, I don't know about that, because it looks like if the father of the baby wasn't lying at the time that he was diagnosed with syphilis, a long time ago, he wasn't. The current partner wasn't one of his partners at the time, and he was treated for syphilis, right? And his RPR is also 1-to-1 right now. RPR can be positive for life, in a lot of patients. So his RPR is 1-to-1. His FTI is positive, which means he was infected with syphilis at some point. But if he was treated already, unless he got infected again, he's unlikely to. He wasn't, seeing this woman at that time. It's unlikely that he passed it to her. So it's possible that she could have acquired it from a one night stand also. That's one thing. The other thing, I guess, is, well, I think you guys already discussed this. Everybody with a positive RPR and a positive FTA, that's it needs to be considered to having been infected with syphilis either actively or in the past. FTAs, they typically have a very, very low rate of false positives. So if your FTA is positive, your RPR is positive, that means syphilis. Then you have to again go back to the patient and ask them if they were treated for syphilis in the past, and look at the titers to try to make a determination of whether this is acute or this is an issue that was from the past and it was already treated. You have any questions about the case?